Hi, I'm Diane Newman. I'm a continence nurse specialist and adult nurse practitioner, and I'm certified by the Biofeedback Institute of America. I've been treating patients with pelvic floor dysfunction, including urinary incontinence, for the past 35 years. And I hope these videos and my workshops help you learn how to do this intervention. It's successful, it's efficacious, and it really can help your patients, as I know it's helped mine. I see a variety of patients with lower urinary tract dysfunction or pelvic floor dysfunction. I see both men and women. Women I see with stress urinary incontinence who receive pelvic floor muscle training. Usually with the women who just have stress, incontinence, leakage with laughing, coughing, sneezing, I work with them on strengthening the pelvic floor. Okay, so again, you do that history, pelvic examination. I also will check the pelvic floor muscle vaginally and rectally in women. Women also present with overactive bladder symptoms of urgency incontinence, urgency and frequency. I tend to see those women and I do the pelvic floor muscle training, but I also add bladder training and lifestyle modifications such as looking for irritants in the bladder that may be causing that urgency or frequency, discussing possibly weight loss, which really would help overactive bladder symptoms as well as stress incontinence. And then with follow-up visits, I reinforce those interventions. Most patients who come to me, though, have mixed urinary symptoms. They'll have both stress and urgent incontinence, and that's referred to as mixed incontinence, and they may have urgency and frequency. I also see, I'm in urology at the University of Pennsylvania, so I also see many patients post-surgical treatment. They may have undergone mid-urethral sling for stress incontinence. They may have undergone prostate surgery, either cancer or they may have prostatic enlargement and undergo procedures, and they may develop a symptomatology after that. I will do a modified examination. Usually I do a bladder scan to make sure they're emptying their bladder. I will do an abdominal and exam to feel for any types of abnormalities. Of course, I have done a bowel history. It's not uncommon sometimes for me to palpate hard stool in the abdomen in some patients. I see quite a bit of urinary patients who have constipation. And I do a pelvic exam in women and a genitalia exam with both rectal and men and women. And I do a pelvic floor muscle assessment at that time. There is a population that I refer onto urodynamics. And many of my patients have seen other providers. I'm a tertiary center, so they probably have tried drug therapy if they have overactive bladder. So especially if I'm not sure what's going on, if they're diabetic, if they are neurologic impairments such as MS, I will probably send them on for urodynamic studies. With stress incontinence, I tend not to refer for urodynamics, and some of my overactive bladder patients are pretty uncomplicated. I don't necessarily refer them on for UDS or urodynamic studies. We don't do cystoscopies on these patients, so that's really not unless there's something else going on like a history of stones or urinary tract infections, that type of thing. And then as part of after I do the assessment of the physical exam, I then on that initial visit will do a biofeedback session with those individuals with or without electrical stimulation. At the first visit, when I'm testing the pelvic floor muscle in a male or female patient, I will do a digital exam. In women, I put 2 fingers in the vagina and I feel the pelvic floor muscle. The first thing I tell the patient is, can you feel my fingers in your vagina, okay? Do they have that sensation? A lot of women, especially aging women who have atrophy, do not have sensation in the pelvic floor. I then will press down because you will feel the muscle 1 inch intravaginally. It almost feels like a ridge that's, surrounds that you can feel in the vaginal mucosa. So I'll tap down and say to the patient, posteriorly I'll tap down, I'll say, do you feel my tapping there? And usually they'll say yes, and I'll say, well, that's the muscle. If you have an older female that has some vaginal atrophy, who may have some vaginal stenosis, I'll use 1 finger. In men, I will do a digital rectal exam because, again, the pelvic floor muscle surrounds the rectum, and I'll say to them, I want you to contract your rectal sphincter around my finger. So I will do both examinations in males and females. Also in women, I do a rectal exam also, and I also will probably feel the rectal sphincter muscle also. Many providers will ask me, do I do biofeedback on every patient? And I have to tell you that for initial visit, I use my biofeedback usually as part of my initial assessment after my physical examination and my history taking, which is very important. I usually also require most patients to do some type of diary for me. In patients with pain, I do a pain map where I give them a picture of the body and they note where the pain is and when it occurs. So assessment as far as history, physical examination is integral to what I do. And then I usually always do a pelvic floor muscle assessment training with my biofeedback. As far as subsequent visits, I try to see them back within 4 weeks. You know, it's sometimes hard to get people to come back, and most of my patients are working. I do the biofeedback usually initially for the first several treatments. I also will do electrical stimulation in certain patients if they really do not know how to isolate that muscle. But again, I utilize this biofeedback. I find it as a fantastic tool for education as far as for assessment of the pelvic floor muscle. Most people who come to see me, whether it's a male or female, whether they have a surgery or not, or they're referred from another provider, will tell me that they did not know what they're doing with their pelvic floor muscle. And then whenever I hook them up with either surface skin electrodes or an internal rectal or vaginal sensor, they start to understand what does it feel like when they contract, because they can see that graph. So I think the biofeedback is really integral to my treatment process. First want to mention that was so very important is that you start any visit with hand hygiene, whether it's hand sanitizer or whether it's washing your hands. And then of course, always gloves. As far as inserting a vaginal rectal probe, of course you are gloved. If I'm putting on the skin surface electrodes, I am gloved. I'm putting them on. And then usually what I do is I remove the gloves once the patient is set up and I go to the equipment. Before removing a vaginal rectal sensor or removing the skin surface electrodes, I again put on gloves. I usually sit to the right of the patient. The monitor set so that the patient can see it. Here we can be down at the foot of the table, or it can be next to the patient, depends on what works for you. This is an exam table. You can also use a chair, but I use a table because I do a physical examination before I start my EMG, biofeedback assisted pelvic floor muscle training. And this is kind of usually what you would see as far as in my practice. But you can use a chair. The patient can be sitting on a chair. Sometimes with an internal vaginal sensor, it may not be as comfortable for the patient, so you have to decide within your practice setting. You know, a question will come up, how should the patient sit? Do they sit like Joe is sitting here? Now I have skin surface electrodes. If you're using a rectal sensor, and this may be a patient who has not recently had rectal prostate cancer surgery, he may lie on his left side, okay? And so you would insert the rectal sensor, and then the monitor could be on that side of the table that he views while I'm working over here. So sometimes that's actually a preferred position for male patients. I would have now I'm using an exam table here. I would have the exam table flat and he would just go on his left side. Sometimes that's even helpful for a new patient. Maybe if Joe was, say, 3 months after the prostate, and I get patients, male patients, 2 years after prostate cancer surgery. They may have a rising PSA, need radiation therapy because of that rising PSA, and they have some incontinence, and they're referred to me by radiation oncology or medical oncology, and I will use a rectal sensor maybe in some of those patients. I would do that initial visit. I would check his rectal sphincter muscle lying on his left side there, lying on the left side. I do a digital exam, a digital rectal exam to see what type of strength he has in the muscle. And then I may use surface skin electrodes, the same thing, or use a rectal exam depending on what makes some sense. Joe's here today. He's one of my patients who is coming to me referred by one of my urologists because he had prostate cancer surgery around a month ago. And you're having problems with leakage. How many pads a day do you think you're using?
4 or 5.
Really? Okay. And then the other thing that's important is which pads are you using? The ones that have the adhesive on the back that you put in the underwear, or one that you pull on, we call them protective underwear. Which one are you using?
Adhesives.
Adhesives, okay. So 4 or 5 of those. That's a really important thing to find out. You know, people don't go around with a cup to see how much they're leaking and tell me, oh, it's 1 ounce. They're using absorbent products. Incontinence products is the preferred ones, not sanitary products that we use for menstruation. But the thing is, they want to use the incontinence products. They're more absorbent as far as for containing urine leakage. I try to determine what type, because if they're wearing a larger product, which is an adult diaper, those are more absorbent. Now, if Joe had told me, well, I'm wearing 4 of those, right away in my head, I think as a clinician, wow, You know, how saturated are those? Because those are heavier products, so he may have quite a bit of incontinence. But he told me he was using the pads, so they go in the guy's underwear, okay? So usually briefs they can use. And that tells me that he's probably maybe moderately. And then the next question I'd ask Joe is, how wet or heavy are those pads?
Medium.
Medium, okay. So that gives me an idea. I always like to know whether he, you know, I have men that will tell me, all I do is wet, I don't urinate at all. And then I have some that'll say, well, Joe said, well, they're medium, which means that you're urinating during the day?
Correct.
Yes, okay, good. What about at nighttime?
Sometimes occasionally through the night.
Yeah, okay, good. But less incontinence at night?
Yes.
And that's typical. So why Joe said he has less at night, and what you'll see in a guy who's undergone prostate surgery, whether it's cancer or other prostate surgery, is that when you're flat, you're not going to leak. It's going to be with effort. And I have a picture that I always show patients of what's going on in this area. So this is kind of you cut in half, Joe. This is your front and this is your back, okay? So this is your pelvic bone. This is the tailbone. This is the bladder. This is the urethra, and that goes through the penis, and that's where the urine comes out, okay? And one thing to remember is that you have curves in the urethra. And this is the rectum. And then your loops of bowel, there's a lot of loops kind of lie on this area. So one thing I always ask is, how are your bowel movements since the surgery?
A lot better.
A lot better. Okay, so that I ask about that because if you have hard stool, it'll push that urine out, okay? And sometimes, you know, they operate right in front of the rectum. That you know, could happen. You know, I asked Joe about, you know, how his stools are. That's something that's very important, whether it's a male or female patient. Anyone who has constipation, and the data shows that women who strain at stool, that's a British term, and what that means is they really strain and push out to have a bowel movement, are going to end up with pelvic floor problems. So if I find someone has significant constipation, is not regularly moving their bowels, or has hard stool, I actually stop there and do a lot of work with bowel management, because unless I can get them to regulate their bowels and make passing that stool effortlessly, their bladder isn't going to improve. So it's something to remember when you do your history and your teaching. But Joe's fine with his bowels. But let me show you what they did with the surgery. So basically they went in robotically. So you had robot surgery, prostate surgery. So they go in and they cut here at what we call the base of the bladder. And they cut here and they take out this whole piece. Okay, so you took out the prostate. They take this stump, we call it the stump of the urethra, and we sew it back here. You have a valve here, it's called a sphincter. It's here, and you have one in the rectum. And it's normally like this. So it has what we call static tone at rest, which means it's contracted. You don't have to do that. That's just its norm, and that keeps the urine in. Same with the one in the rectum, that keeps the stool in. And the pelvic floor muscle hugs it, okay? The degree of incontinence is how much trauma to that valve. Now, he did not cut the valve. If he cut it, you'd be totally wet, okay? Because it could not hold anything. But there's fine nerves that are around here that kind of keep that valve really strong that may have been cut, okay? So if you work your pelvic floor muscle, you will provide the support to close that. Now, by what you told me about the amount of incontinence you're having, it's only maybe a little bit open, okay? So it's, you know, if the muscle, the valve, the sphincter's like this with the muscle hugging it, Joe's is probably just a little bit open, okay? And what do you find that when you leak mostly? At night you told me you don't have a problem, right?
During activity.
Yeah, during activity, right? Typical what I hear is bending over, lifting the leg. I have some guys that tell me when they're going into their car, their truck, they leak.
Yeah.
Yeah, and I know that you're doing some miles walking every day now, right, to get back?
Trying to get back.
Yeah, and you having problems with walking?
Occasionally.
Yeah, okay. So that's more activity, the more leakage you will have, but you're not harming yourself. So I don't want you stopping any kind of activity because you want to get back to some, you know, activity, exercise to, you know, get your health back after surgery, but it'll take some time. Okay. So today what I'm going to do is I want to test this muscle. Now, I don't put anything in here. I actually put something outside the rectum. And what I do is I put sticky things outside, okay? And it picks up, I have you work the back part of the muscle. So I stay away from the front because I know with the cutting in that, the sensation isn't as great as it was before the surgery. So what I'm going to do is have you work the back part. And since it's like a hammock, so when you look at this muscle, it's like this in the pelvis. So this is your front, your back. If you work the back part, you will start to pull the entire muscle. So at the beginning, you'll feel it not near your rectum. But what most men will tell me is after a few weeks, they start to feel their scrotum move. Okay, because the scrotum is right here. So the muscle's pulling it up. The other thing about this muscle, we call it pelvic floor muscles, because even though it's one large skeletal muscle, which is your thigh is a skeletal muscle, okay? This has many, many layers. And there's more layers in the back because that valve in the back and the rectum has to be even have stronger support because stool is heavier than urine. So when you have stool that goes in there, say you're not near a bathroom, you don't want it falling out, right? And you don't have any problems with that? No. Okay, fine. Okay, so that's usually the teaching I do with a male patient, say, who comes to me after, say, some type of prostate procedure. Now, not all men who see me is because of prostate issues. Many of them come who may just have urinary symptoms. I see men, I see students who are in school who may have increased heightened anxiety because of school, who come to me with increased urgency frequency. In those individuals, I teach bladder training and I teach them how to work the pelvic floor muscle to control urgency. So I see men and women from the age of 18 and up. So that's usually my patient population. We've already gone over Mary's symptoms. I've determined whether, what her symptoms are, mostly urge incontinence, overactive bladder urgency frequency, or stress incontinence. And then usually after my physical exam, I will do an EMG biofeedback session. I really, this is usually my routine is I sit with the patient and I give them instructions on exactly what I'm going to do and what is going on in the pelvis. I have created a board here of the pelvic floor muscle, and this is, of course, women. And I find it's very, visual, and it's important to explain to them what they're going to do, where the electrodes are placed, so you can show them if there's a vaginal sensor that's going in the vagina, that's there. And, of course, I have a skin surface electrodes around the anus. But, Mary, I want to go through with you, what I usually teach. So this is basically you look at you sideways. This is your front. This is your back. This is the pelvic bone. That's the tailbone, so that's kind of what you sit on. Here's the bladder, the urethra. It's in women, it's a pretty short tube, but it carries the urine to the outside. The uterus and the vagina. The rectum, and then the opening to the rectum is the anus. And then the loops of bile, we have lots of long loops of bile that kind of just lie on this whole area. This is called the pelvic floor because all of these organs sit in the pelvic floor, okay? They don't really kind of sit up like this. They kind of mush down, you know what I mean? Yeah. Of course, as the bladder fills with urine, it ascends up almost like a football. But this purple thing is the pelvic floor muscle. So it's in the floor of the pelvis. It attaches to the pelvic bone in the front, and it goes around the rectum and comes back around the other side and attaches on the other side of the pelvic bone here. It's like a sling or a hammock, okay? For us women, it's a very much a supportive structure, so it really supports the bladder, the uterus, and the rectum. When we have babies, I know you've had 2 vaginal births, right? And that one baby was really kind of large, right? Yeah, so actually this muscle enlarges, all right? And for a lot of women, after subsequent births, sometimes it doesn't go back to this, where it was before having a baby. And so today I'm going to see if we can get you to strengthen this muscle. What I tend to do is a lot of us don't have a lot of sensation in the front of the muscle. So I have put those sticky things outside your rectum here. And I'm going to have you contract the back part of the muscle. And as you tighten, over time, you'll lift the whole muscle. This muscle is an important structure because here around the urethra, there's a valve. It's called a sphincter. There's also a valve in the rectum. This valve has static tone, and by that I mean that at rest, it's contracted, okay? You don't have to tighten up or anything. That's its norm. The pelvic floor muscle hugs it, okay? When you go to the bathroom, and the norm for a woman, of course, is to sit and urinate, okay? You relax your pelvic floor, which opens a valve, and you don't even think about that. That's kind of an automatic thing, all right? You have incontinence because that valve is weak and that muscle's not as supportive. Now, as I said to you, you also have a valve here, and that is also contracted at rest, and it keeps the stool in. Now, we call these the pelvic floor muscles because it's really one large skeletal muscle, like your thigh. Your thigh is a skeletal muscle. This is also, but it's many more layers in the back. Because stool is heavier than urine, right?
Right.
It's, it's heavier, right? And the thing is that we need that muscle to be stronger in the back so that we don't lose stool.
Right.
And you don't have that problem, so that's really good. All right, so what I'm going to do is have you tighten the muscle by tightening your rectum like you're holding back gas. One of the hardest things that I find for patients is to isolate the muscle. That means that to really just contract this muscle. Because there's other muscles here that I don't show on this picture, but your butt or your gluteal is a muscle, okay? The stomach, we call the abdomen, has a muscle. And what a lot of people do, and of course you have your thigh muscle down here, is that they contract these other muscles at the same time.
Right.
So what the biofeedback is helpful for is for you to just isolate. And that means just find the right muscle to contract, okay? All right, so Mary, we talked about the fact that you have stress incontinence, which is leakage with laughing, coughing, sneezing. That's usually, remember I showed you the picture with that sphincter is weak, and that occurs sometimes with childbirth and then as we get older. I want to make sure that you work the entire muscle. And this muscle, like I said, is a skeletal muscle. So it has something we call fast twitch and slow twitch muscle fibers. Fast twitch muscle fibers build strength. Slow twitch muscle fibers build bulk. The majority of this muscle has the slow fibers. But to explain to you about fast twitch muscle fibers, are like a basketball player who jumps, keeps jumping to make that basket. They're the smallest portion of this muscle, but they really, if you work it, will really build strength and get some of the strength back that you've lost. But we need the slow twitch muscle fibers to really build endurance, which means that, with a hard cough, that whole muscle is very strong and keeps that sphincter, that valve tight, okay? I'm telling you this because I'm going to have you do two different types of contractions. The fast twitch are 2 seconds in length, and the slow are 5 to 10 seconds. And what we're going to do here is test what you can do with both of those types of fibers, okay?
Okay.
This is a vaginal sensor. It goes in like this. This stops at the introitus. These 3 electrodes will pick up the muscle contraction on EMG, or they can be used for electrical stimulation, and they will send that electrical current. So you would use this sensor. Many times patients are unable to isolate the muscle. Even with a physical exam, you may have work with them on identification of the muscle with your finger, but they may not have a lot of pelvic sensation. That happens with women who may have had delivered vaginally, large babies, or I've had a recent woman who had twins. So electrical stimulation would help because electrical stimulation sends a current to the muscle and it causes a contract, and they can feel that current. Now this is the rectal sensor. The tabs is inserted into the rectum. This is at the anus, okay, the opening to the rectum. This tab sits right there. Now again, you want that patient to not bear down. They're going to tighten up or tighten around the sensor. That's what you want to tell them. It's an important concept because initially a lot of patients who are just starting pelvic muscle therapy will Valsalva. They will bear down and push out. Contracting the pelvic floor is the opposite. It's pulling up and in, either vagina or the rectum. Many times what I'll explain to a patient is that it's like you're holding back gas. So if you were in an elevator full of people and you felt like you were going to pass gas, you don't want to embarrass yourself, most people would tighten around the rectum, pull in their rectum. That's really what a pelvic floor muscle contraction is. That's the muscle that you're using. So once you remove these from the patients, you want to do some type of system. Some people will keep them in a container with the patient's name in their office for use for the next session. Others will give it to the patient to take home and bring with them at the time of their next visit, but they're individual patient sensors. Now, as far as cleaning, when they come out of the body, you really do want to clean them before having the patient take that or before storing it. And in each bag of the sensor, there is instructions, the recommendations of the manufacturer. So please read these and make sure that you review these with the patient because they may find that they also want to use this sensor at home to do pelvic floor muscle contractions as a resistive device, but they need to clean in between use. So this is the cable for the skin surface electrodes. The green is a grounder, so I put it either on some bone, the knee or the hip bone. And of course, these are the two sensors that pick up the muscle contraction, and they're red. You can see very easy, you match up the colors and you just put them in. What I really like about this is that when I'm done with the patient, I just remove these and throw them away. Since they're on the table with that exam, I will then place these at that point around the introitus at either 10 and 4 o'clock or 9 and 3 o'clock, and you'll see this picture. So in here are my treatment protocols. So I'm first going to start with one single EMG, 2 work, which means 2 second contractions with 2 second relaxation. And it counts down from 5 to 1. And then what I usually do is just use this to see where that relaxation is. And as you can see, it's kind of jumping around. So Mary, I want you to try to really relax. Now, in many cases, the patient may not be able to do this, all right? This may be what you find for their relaxation. I don't sit there and say, oh, that's not very good. I say, okay, that's fine. Now I want you to try to contract. And remember, I want you to contract around that sensor in your vagina. So contract, tighten, tighten, tighten. Very good. Tighten, relax. So what I'm looking at is if the relaxation starting here is, I think, high. Anything under 2 is normal. But I look for what to me, the strength of this muscle is. You go from the relaxation level to the contraction. This is not uncommon in women. I find that they have a difficult initially with relaxing the muscle and contracting. So what I do is usually just wait, because as you can see, she's gone down a little bit as far as her relaxation. So this to me is a practice session. Now try to contract again. That's it. Hold it, hold it, hold it, hold it, hold it, hold it, hold it. Good, relax. Very good. Now I'm going to see if she can do a quick contraction. So contract, 1, 2, relax. Good. Contract, 1, 2, relax. Very good. See how that's better? You'll find that as they keep, that's good. Those are good. Now just relax down. You'll find that, to relax the muscle, you have to contract it. You see, as she started doing this, she's relaxing better. Now just relax. And now it's creeping up a little bit more. So we're just going to let her relax. All right, contract, 1, 2, relax. Good. Contract, 1, 2, relax. 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 So what this is showing me is that it measured her contractions. It's going to give me an average, and that's what your report is going to show. And as you can see from this is that, her relaxation is probably between 3 and 4 on an average. It's pretty consistent though, so that's where her relaxation is for this visit. But what I'm looking for is, can she contract? And the differentiation, the work-rest differentiation between the work and the rest, the work and the rest. And you can see the consistency of those contractions. Then what I usually do is I will exit out. I then will go to view. And this is going to give you as far as the patient's name. And then what you're going to see is a report like this. I print this out, and this is scanned into my electronic record. It's giving me the average of the work, average of the relaxation, and then the differentiation between work and rest. This is what I actually scan into my chart. What I'm going to do is, I showed you this picture before. I really have explicit instructions, and I have a prescription that I give you. I call it the pelvic floor muscle prescription. It's all written down. And basically, it tells you that you're going to do quick and long contractions. You're going to do 10 sets of each. You're able to hold it for about 5 seconds. So we're going to start with 5 seconds of the long contractions, okay? Eventually, you'll build up to 10-second holds. you're going to do a set in the morning and at night. One set equals quick and the long in 3 positions. And again, I'm going to have you work right now the back part of the muscle. In time, if you work the back part, you'll start to feel the entire muscle pull in. You'll start to feel the vagina pull in.
Okay.
Some people never feel it up here by the urethra because it's not a sensation that necessarily that you would feel, so don't worry about that. I do not want you to do these exercises when you urinate. Okay, a lot of people want to do them when they stop and start to stream urine. I don't want you exercising then. I never want you to interrupt urination, voiding, okay, peeing. So you're going to do this set in the morning when you wake up and before you go to bed. And I have a lot of other information for you as far as where you can do them. You can do them lying down on the bed, sitting can be in a chair, standing. Most patients tell me that the hardest is standing because they don't feel the muscles much. When you sit, you kind of feel it. Like here, you were feeling a little bit more, right?
Yeah.
So, but that's okay, okay? It just will take time. This is not something that happens overnight. I want to see you back in about 2 weeks, and we're going to do the session again. I don't expect you to come back and say, Diane, everything's better. I don't have any more. I'm not leaking at all. That's not what happens. It's a slow change, okay?
Okay.
And it may take a couple months, all right? So I don't want you to get discouraged,
Okay.
okay? All right, let's get you dressed, and then I'll give you all the information, all right?
All right, very good.
Thanks so much, Mary.
Okay.
And what I'm going to do, one of my protocols is 5-second work, 5-second relax. So that's the one I'm going to use. I'm on a single EMG. And again, I don't want you doing anything, just I want to see what your relaxation is. Last time it was a little bit high. Oh, that's good. You're down. You're up there. Last time you were up between 3 and 5. Now you're below 3. Very good. Now, these you can see 10, 15, 5 seconds. So I'm going to try to have you hold the contraction for 5 seconds. That's okay. That's good. When I tell you to do that, that cough actually, it's good to see what happens. See what happens when you cough? Okay, now tighten and hold for me. 4, 3, 2, 1, relax. That's excellent. See that? Very nicely, you dropped it right down. Just relax. Tighten and hold. 2, 3, 4, 5, relax. Now I'm going to pause this, which is nice. With this biofeedback system, you can pause and then you can teach the patient maybe during this time, explain to them what's going on, or else just give them a little bit of a rest. You can see I was using a practice session here. Now I'm going to go to a measurement. But what I see here is that relaxation's a little bit around above 2, but this is much better than you were last time. So I think you're really getting the hang of to contract them, also relax it. Consistently, she holds. Now, what I look for is, can you hold it for the 5 seconds? That's very good. You drop it immediately back down to relax your relaxation base, contract again. So this is a really good reading, okay? What do you think? You think that looks good?
Yeah.
Yeah, it's better than last time, isn't it?
Yeah.
Many times patients will say to me, well, I want to compare what I was last time. Even sometimes I print out these graphs for them to take home. It's also, I think, a motivator. You know, in my previous practice, I used to give out stars if they were better. Anything that you can do to reward the patient. It may sound trivial, but it's very, very important. A lot of behavioral therapy is about positive reinforcement for the behavior you want. In this case, I wanted her to improve her relaxation, and I also wanted her to be able to try to sustain the contraction for the 5 seconds. So to me, you achieved that goal, okay? To me, this is a very good visit. So let's do some measurements. So now what I'm going to do when I start is I'm going to start with measuring it, because what you want to make sure that you do is that I always document the visit. I do a documentation in my electronic record. I interpret what this shows me. In this case, what I may say is that relaxation is still slightly above normal, and I would give the average amount of, for the microvolts for relaxation, but that it has improved since her previous visit. I will also talk about the height of the muscle contraction, what that average microvolt would be, and whether she's able to sustain the contraction. I will talk about whether she's using accessory or co-contraction of other muscles or not. What I do with many visits is that I will put my hand on the stomach, say, or watch, are they lifting or whatever. If they're lifting, I know they're lifting their gluteal muscle, which you don't want. If they're sitting there, then you know they're contracting their abdomen. You can also monitor for the abdominal muscle by using the second EMG, and I recommend that, especially when you first start testing that individual patient. So let's try this again. Tighten and hold, 2, 3, 4, 5, and relax. Tighten and hold, 2, 3, 4, 5, and relax. Great. And that's nice that you were able to pull that contraction back up. That's good. Tighten and hold, 2, 3, 4, 5, and relax. Tighten and hold, 2, 3, 4, 5, and relax. So let me go over what we see here. Relaxation is very good. It's under 2, which to me, under 2 microvolts is considered within normal limits. What you see here is a very, very nice contraction. Relax, she's able to hold it for the 5 seconds as I cued her, drops it right back down to relaxation. And as you can see, pretty consistent. She was even able to recontract the muscle. So this is really a very nice pattern to muscle relaxation and contraction, especially for a sustained 5-second muscle contraction. At 1, I'm going to have her start to contract. Now contract and hold, 2, 3, 4, 5, 6, 7, 8, 9, 10, and relax. Very good. She relaxes down. Excellent. Very good. Now 10-second relaxation. Now contract and hold, 2, 3, 4, 5, 6, 7, 8, 9, 10, and relax. And as you can see, between these 2 bars is 10 seconds, between, again, 10-second relaxation. Excellent relaxation. Contract and hold, yes, 2, 3, 4, 5, 6, 7, 8, 9, 10, and relax. Now I'm going to pause this because I think there's some interesting things about this graph with this patient. Number 1, excellent 10-second contraction, pretty consistent there. Drops it right down to muscle relaxation, below 2, normal. Again, can easily pull it back up for 10-second contraction, drops again. And what I do see as a patient continues to contract, relax, that relaxing may even improve further. But this is actually an excellent graph for someone as far as 10-second holds. So, this is something that, you would love a patient to achieve to, as far as being able to really sustain that slow muscle fibers, as far as the slow twitch muscle fibers, as far as holding that contraction for 10 seconds. So this is probably something I'd print this out and give this for the patient to take home and tell them, good job. When I originally saw you, you just had urine leakage with laughing, coughing, sneezing, right? Mm-hmm. But now you mentioned something about worrying about getting to that bathroom.
Yeah, I find that when I'm doing yard work or I'm taking a walk, I wait too long to go to the bathroom, and then all of a sudden I have to go really fast. And if I'm away from the house or out in the yard, it's quite a rush to get back, so I have to usually be prepared.
Do you notice any leakage after that urgency, or?
A little, yes.
A little, okay. We'll talk about maybe using your pelvic floor to try to help that. Tell me how often you're getting up at night to go to the bathroom?
Oh, 2 or 3 times at least.
Okay, and do you find that you're drinking more in the evening hours when you're home from work?
Not as much as I should be, but yes, I am drinking more.
Okay. Any coffee, tea? You like coffee and tea?
Yes.
Yeah, I know. We'll talk about that too.
Okay.
But about during the day, I know that you work in an office, and I know you probably get really preoccupied in that. How often do you think you're going to the bathroom during the day?
Because of this problem with the urgency, probably 4 or 5, and maybe I feel like that's too many. Okay.
And you think you're going more and more often then, huh?
Mm.
But then there's sometimes when you delay it, right? How's your urinary stream is strong? You don't feel you have any problems with starting to urinate when you get?
No.
No. Okay, fine. Well, you know, that is not, remember we talked about the stress incontinence being more related to the valve and the sphincter being weak. Well, you've been trying to strengthen that. But urgency and some incontinence after urine leakage, after urgency, is usually related to the bladder, not necessarily the valve, okay? And as we get older, especially as we get to menopausal years, I find that more and more women experience this. And you also want to really look at nighttime. You getting up because you feel like you have to go to the bathroom, or you just wake up and you go to the bathroom? Because nighttime is a kind of a different kind of symptom.
Feel like when I wake up, I have to go to the bathroom. I think I'm waking up because I have to go to the bathroom.
And have you ever been tested for sleep apnea?
No.
No. I'm asking Mary this because one of the biggest causes of nighttime voiding, which is nocturia, is sleep apnea. And I find that patients use a CPAP machine. If they're tested, actually that nocturia goes away. So it's something to think about. Also, a lot of times, you know, snoring is a sign of sleep apnea. And sometimes when I get couples that come to see me, the spouse, the husband or wife will say, oh yeah, they snore a lot. And sometimes they know that possibly there's a problem. But, you know, I'm just telling you all causes. The other thing, I had tested Mary at the first assessment. You know, she doesn't have swelling, you know, edema. During the day, you're upright. As we get older, you're not that old yet, but, you know, as you get older with some high blood pressure and that, our fluid goes to dependent areas, and that means in our ankles, in our butt, really. And then when we lie flat, you get rid of that fluid, and that can cause you to wake up at night. So you want to look at all these other things that might be causes, but you don't seem to have any of that. But I will tell you, you're not a smoker. Smoking can trigger some of the symptoms you're talking about. I talked about diet, and I'll give you a list of things. Besides products that have caffeine, we're just not talking about beverages. They're now putting caffeine in a lot of products like mints, any energy drink. Yeah, so think about that. Tea has caffeine. Sodas have caffeine, even diet sodas. I sometimes see it with artificial sweeteners. You don't have diabetes, so I don't think you're doing a lot of diet products, right?
Not really.
No, okay. But sodas, you know, can have quite a bit. But I'll give you a list of that. In addition to caffeine, I sometimes find tomato-based spicy foods can also trigger it. Some of my patients say, oh, you took away everything I like, Diane. But it's not to do that. It's to try to get you in control and decide what may be affecting you when you make the decision. You know, not that you stop it. Like maybe on the weekends when you're home, don't have to worry about driving to work. You just have as much coffee as you want. You know what I mean? Because the bathroom is nearby, okay? There's usually no real big other cause of that, but there are some things that can really help besides just looking at your diet. Another one is bladder training. And bladder training has some of the best research out there. It really is teaching you how to control urgency. What you're doing is what I find a lot of people do who have those symptoms is that they'll start to go more frequently because they're worried they may embarrass and wet themselves, right? Yes. And you've been doing well. You know, when you first came to see me, you told me you're wearing those 3 pads, and now you said you're only wearing like 2, right?
Yeah, sometimes 1.
Really? Well, that's really good. So the incontinence is lessening, but I don't want you to worry about that it may go back up because of the urgency. So the goal is for you to control the urgency, okay? So what this is that the urge to urinate starts, it peaks here, and then it goes away. And this is when we all run to pee. And what it sounds like is you're trying to really rush there, right? And what I want you to do is to learn to not go to the bathroom when it's strong, but to wait. And the concept here is that I know you think you're waiting too long, but I want you to change. Right now your bladder's controlling with that urgency. I want you to control the urge, okay? So I'm going to have you do some things. If you get rid of the urge when it's strong, you'll have more time to get there, and you probably will not leak urine if the urge is not as strong. So there's a couple of things you can do, and don't worry, I have all this all written down for you. So it's reviewed. So, you know I give you a lot of information, so I really like to give out in writing so that you can read it whenever you're away from here and can spend the time. So there's a couple things you can try. You can use that muscle to delay urgency. If you quickly contract the pelvic floor muscle a few times, that urgency will go away. But one thing, another kind of technique, it's called an urge suppression strategy is what it's called, is actually deep breathing. And this sounds simple, but it really works. So when you're home relaxed, don't do this at work or you're stressed out. Remember, stress, anxiety worsens the bladder.
Mm-hmm.
The same area of the brain that manages emotions manages bladder. So if you're stressed out, worried, oh my goodness, I'm not going to make it there, or I'm in a meeting or whatever, what's going to happen? It just makes those sensations in the bladder worse, okay?
Yeah.
So when you're home and relaxed, okay, and you get that urge, all right, I don't want you to rush there. I want you to sit down. And what you're going to do is you're going to close your eyes and you're going to do slow, deep breathing in and out of your mouth slowly, okay? What will happen is that you concentrate on your breathing. You'll find that the bladder will relax. Then you wait a few minutes and then go to the bathroom when it's not as strong, okay? If you wait too long, it'll come back even stronger. I want you to work on this. Now, again, I want you to try this. If you're successful once or twice a week, I think that's success. So don't expect this to work all the time for you.
Okay.
But again, you can use that pelvic muscle because you're really doing a good job with isolating it and knowing when to use it. You can contract it a few times. And they've shown that if you contract the pelvic floor a couple of times, you actually break that nerve impulse to go to the bathroom. It's been shown to do that. So I want you to try those things, okay?
Okay.
A bladder diary gives me an idea of how often you're going to the bathroom. It's very simple. If you want, you can download an app on your phone for a bladder diary. I'm going to give you a paper one. It's up to you. I just want you to keep it for 1 or 2 or 3 days. What works for you, do on the weekend. I'm not going to have you measure your urine with the diary. I'm just going to have you put down when you go to the bathroom, because I want to know how often you're going. If you have any strong urges, if you're leaking urine, how many pads you're using, and then what you're drinking. So then I can see if there's any correlation. And then keep it maybe for a day or 2 and bring it to when you come next time for your appointment. Or you can scan and email to me and I'll go over it. You're on the patient portal, so we can talk that way too, okay?
Okay.
All right, listen, great seeing you again. Thanks for coming back.
Thank you.
I want to thank the Prometheus group who has sponsoring these videos, but has really provided some excellent equipment, specifically biofeedback equipment that I use with pelvic floor muscle training, as well as electrical stimulation. I've used them for over 30 years. And I hope that you find this type of modality as helpful as it's been for me and my patients.